metformin had been the cornerstone. But now, yes, recently we have got the liraglutide, which has been approved. Dulaglutide also has got some studies, as well as you said, empagliflozin is the one which is used as SGLT2 inhibitor. So we'll try to carry forward from there and more or less also focus on how do we manage in terms of the complications of diabetes, because they are a major problem, and with type 2 you expect complications to be much more significant. So what are the difference in terms of the profile of complication that you see for type 1 diabetes in adolescents and type 2 diabetes in that regards?
The prevalence of associated comorbidities like MSMD, hypertension, will be higher in type 2 diabetes, whereas diabetes-related complications may start appearing in.
So even at diagnosis, you will have to screen for complication. That's a big message, because in today's study, they found a significant proportion to have those complications right at offset. While in type 1, you say, okay, you wait till puberty, you wait till around at least 2 years post-puberty or 5 years if it's prepubertal onset. So how do you decide about management? So if a child presents to you with non-osmotic features, HbA1c less than 8.5%, start metformin. I think that's pretty simple. If there is improvement, you continue, and we have shown these will be typically patients who you pick up by screening. If somebody comes to you with symptomatic, this will not be the case. Their 8.5 HbA1c is impossible. So this is somebody you said, okay, let's do our obesity screening. You may find somebody has HbA1c is 7, 6.5 also, which may happen. If there is no improvement, however, think of basal insulin, and I would now go more in favor of a GLP-1 receptor analog or even a empagliflozin as an option. Now, if there are osmotic symptoms, HbA1c is more than 8.5, they will consider basal insulin with metformin. If there is no improvement, you increase the dose and add prandial insulin. But now I would say this is the time to think of GLP-1 receptor analog. Our study, we had 11 patients who were started on insulin and 8 of them were able to stop. Nearly all of them whom we are able to stop were on additional GLP-1 receptor analog or SGLT2 inhibitors. So metformin alone is not going to help you wean off patients on insulin, especially if they are on a basal bolus regimen. You have to start something else, then you can stop insulin, and then maybe you can taper off the data subsequently from there. If there is DKA or honk, you start on insulin. Do not start metformin unless acidosis is completely resolved. And then you go from there as to how the protocol is working in that perspective, and that becomes important in that regards. So if HbA1c is less than 7%, that seems to be the target of adding. And now the approach is more of treat to target and not treat to failure. So as I said earlier, people used to say, okay, let's try lifestyle and see in 3 months what happens. Then you say, okay, let's start metformin and see in 3 months. No, now they say if you want to be aggressive right at the beginning, because if you have good control in the beginning, you will have a good impact later on. And this is known as a legacy effect, which I mentioned last time also. And if HbA1c is more than 10% on follow-up, you should always say, okay, is something going wrong? Shall I consider starting insulin in this perspective? So the concept is hit early, hit hard. So 18-year-old girl, fasting sugar of 188, 2R 340, HbA1c 10.1, ketone 1.2, BMI, there is obesity, there is acanthosis, C-peptide is detectable, GAD negative. How will you start, Dhwani, in this case? Yes, ketone is also high. Ketone is present at least. Yeah, so I would be a bit cautious. We can start with glargine, definitely requires insulin, and plus minus basal bolus, so you can start with metformin. So had a response to metformin at 12 months, there was poor adherence and there was weight gain. HbA1c is now 9.2 and SGPT is 76. So what's happening? What do you do now? So you should think of some other medication, and in this regard, you can increase metformin, and GLP-1 receptor analog will be a good agent to consider. 17-year-old boy with obesity, BMI is 42, acanthosis and family history. HbA1c is 14, SGPT is 120. LDL shows 220, triglyceride is 420. What do you think is happening here? Hmm. So it looks like a more likely to be a type 2 diabetes. What about the cholesterol and this triglyceride, all these values?
They are from the long time, so the child must be maybe have insulinopathy, causing this high triglyceride level and LDL.
Or you have a glucotoxicity, lipotoxicity, and all those phenomena will be there. So how will you manage? So started on insulin also, and then because I don't expect from 14% to come down, I'll quickly think of starting GLP-1. Of course, I'll do a GAD antibody and all those things to exclude. So start with insulin metformin, and then you can add GLP-1 quickly within the next week or so, and maybe even bariatric surgery can be considered in this scenario. So now, Dhwani, we have a 16-year-old girl with obesity. Fasting sugar is 146, 2 hours is 224, HbA1c is 8.3, ketones are negative. What are you thinking here? Yeah, so GAD is negative.
Again, it needs to start with metformin and think of an add-on therapy.
Yeah.
How should we use in the next
Yeah, so I think metformin alone will be good enough. BMI is 32, acanthosis, family history is positive, type 2 diabetes. So of course, in this scenario, you can think of metformin as a primary agent. Now, workup showed a cholesterol of 240, LDL of 180, triglyceride of 220, advised statin. Do you agree? And this was done at the time of diagnosis. Yeah.
Repeat the test again.
Because it could be falsely high because of the metabolic decompensation. So essentially better would be to do it after the lipotoxicity is over and repeat lipids were normal. So you don't have to rush to therapy immediately. Follow up at 3 months, Dhwani. Weight loss is there, A1C is 7.2%. Now she complains of vomiting and ALT is 98. What will you do? And earlier ALT was normal.
And at those events, I was just setting continuous metformin, there may be worsening of acidosis and
So there will be a risk of lactic acidosis. So you will like to stop metformin here. Definitely. So anybody who is sick, who develops these symptoms, you have to stop. So like you have sick day for type 1, you should also have some basic concept of sick day for type 2. So a lot of water, control fever, give antiemetics, stop metformin, stop SGLT2 inhibitors, monitor sugars carefully. If sick, admit, give insulin. That will be the concept there. So metformin was stopped and insulin was given for some time, and then there was improvement. At 6 months, ALT is better, now restarted on metformin. HbA1c 6.4 off insulin. Now she has fever, vomiting, and loose stool. So what will you do again? So you will have to, she'll be dehydrated. So you have to again stop the preparation of metformin. At 2 years, stable on metformin, complaint of abdominal pain and gallstone disease. Now she is planned for surgery. What will you plan in terms of surgical management? So you have to stop metformin and start insulin. That will be a significant factor. So again, if there is a sick day, there is iodinated contrast, or there is surgery, you should better stop metformin and start insulin in that regards. At 3-year follow-up was advised complication screening, and urinary albumin creatinine ratio she came up with 380 milligrams per gram. There is a good glucose control. Blood pressure is normal. Now, will you start ACE inhibitor in this case?
We will look for other causes if she's menstruating.
Yeah. Yes. So definitely look for infection, menstruation, non-fasting, exercise. All those factors become important, and you get a history often. So always before you give the sample, you ask, somebody is menstruating, do it after a couple of weeks. So there is no confusion. So post-menstrual was done. So repeat after 3 to 6 weeks was found to be normal. So do not just get biased by a single reading because parents are going to be concerned. I would be wary of starting ACE inhibitors or ARB, as I said, or statin in girls at this age. So that's why we showed those two cases. High LDL, immediately after diagnosis, do not start statin. Single reading of high ACR, which is not fitting into your picture. Child is well controlled. HbA1c 6.5, 6.4. Why would she have nephropathy right away? So think of other things. 18-year-old girl with obesity, fasting 188, 2 hours 340. HbA1c is 10.1, ketone 1.2. There is obesity, there is acanthosis, C-peptide high, GAD negative. We have discussed this case. So you will start off with insulin would be your primary therapy in this regard. You start on glargine and then look for response to metformin. Now, on follow-up after 2 months, there is improvement. Now, what will you do here? She is on insulin. So would you like to continue insulin? Taper off insulin. If you're not able to taper, you should add something else, SGLT2 inhibitor or a GLP-1 receptor analog. So you're finding improvement. Metformin, insulin dose was decreased, controlled well on metformin. So do not just keep on continuing insulin because it's going to cause weight gain. And this is something which is only a stopgap measure in type 2 diabetes. It's not a sort of a measure in which you have to start continuing for a long time. Follow-up after 12 months, 20, poor adherence, weight gain again, HbA1c is 9.2, SGPT is gone up. What do you do here? Yeah. So it's unlikely that she is going to improve from 9.2. In fact, the expert says if it's more than 10, start insulin again, which we don't want to do. So we can do something else here. So you should start a GLP-1 receptor analog, which is going to help in terms of liver. Or you can think of maybe if they're not ready for this costly injection, in that scenario, you can start off at least on a SGLT2 inhibitor like empagliflozin, which is now reasonably available. 8 months later, she had weight loss, HbA1c is 6.8, blood pressure is 134/90. So do you think it's high? So stage 1 probably. And in this regard, the first thing, of course, would be to give a lifestyle measure, salt restriction, because again, we don't want to start all these agents at this point of time. She is too young for that. And then future, once you start them, stopping becomes difficult. So lifestyle intervention, and if there's no improvement, then you can think of a ACE inhibitor or other parameters like ramipril. But again, you have to tell them very carefully that they will need to avoid this when they are planning pregnancy future on, because this is something they need to be understanding. So at 2 weeks, she was started on ramipril. Her BP is good, but she complained of weakness, anorexia, and muscle cramps. What do you think is happening?
Yes, it's like
Yes, so this is something as we discussed earlier, that if somebody has a borderline sort of a renin-angiotensin system, which is actually compensating as a response, if you block that, you may develop a deranged renal function and a high potassium. We had a child with type 1 who within 2 days developed a very, very severe reaction to ARBs and had to be dialyzed as well. So this is something you have to be cautious about in that regard. So ramipril was stopped. And in that scenario, there was clinical improvement subsequently. 17-year-old boy with obesity, BMI as we discussed earlier, very, very obese boy, acanthosis family history, very high HbA1c, high triglycerides. So this will be a candidate for polypharmacy. And probably you will do, what procedure will you think of? Bariatric surgery. So clearly, this patient will require a candidate for obesity surgery. 9-year-old girl with obesity, BMI is 2.2 SDS, HbA1c 6.5. What will you do? So fasting is 90 and 2 hours is 120. So this again highlights the significance of HbA1c, which we discussed last time as well, that HbA1c not at 6.5, but definitely below 6 is not a good marker. But again, how this HbA1c was done becomes important. So whether it was a point of care test, which again will not be reliable, and on follow-up, she now develops, there will be a risk. So she's more like a pre-diabetes. On follow-up, she develops this complication. So what will you do from here? So 7.2 now, which will be the best agent now? No ketosis. 7.2 you won't have ketosis.
That point, like to start with metformin
Or
alone.
just lifestyle.
That-
So there clear-cut indication that if you're diagnosing diabetes, there is no role of just giving lifestyle. You want to treat to target and not treat to failure. So you start metformin right away.